how much time are we cutting out of that type of care that is shown to prove neurological outcome function way better than
Yeah,
anything else?
exactly.
That
Yeah.
was a nice bonus because I was very concerned about cardiac arrest. Again, there's a lot of entities that said that they just don't use it. It's a pain in their butts. We kind of use it in a certain capacity, again, for transport. But we do talk about ROSC. If you get ROSC, the ventilator is the way to go.
The views expressed on EMS In and Out are solely those of the hosts and do not represent any affiliate agencies or employers. This podcast is for educational discussion only. Always follow your local protocols and consult your medical direction when applying any clinical practices discussed. Hello and welcome back to EMS In and Out. I'm one of your hosts, Kyle Goodnight. We got Rob Moyers there too.
Hello, everybody.
Nice to see you again, Rob.
Good to see you.
It is on the cusp of St. Patty's Day. What do you got planned for St. Patty's Day, Rob? Anything big?
Staying away from trouble. Yeah, staying away from the masses. I'm gonna hang out with my wife, and we're gonna have a nice time, and just stay away from amateur hour, which is
Right.
probably gonna be a problem, and the snow. It's gonna be pretty terrible.
Oh,
So
yeah, I
it just
remember a
doesn't seem
couple
like
of
fun.
I remember a couple of St. Patty's Days back when I was younger, and I actually partook in St. Patty's Day that were very cold. But yeah, luckily, me and my area where I run in, we don't have any parades or anything like that. There may be one down in Columbus, but it would have to have all hell break loose for our department to be down there.
There is a massive parade in Cleveland, and unfortunately, for reasons I've talked to you about, I can't participate in the parade march. But yeah, I remember being young and not worrying about the cold as well, and now I'm old
Yeah.
and I just don't want to be around.
Yeah, it used to be a fun little, break holiday for me. And I just haven't, I've got a couple of friends that still really dig it. I don't know. It just fell off for me, and what's crazy, I'm a March birthday. My birthday's on the 20th. And,
Oh, all right,
so,
man.
if you guys want to support my birthday, feel free, we'll put a link in the description where you can donate money to the cause. It would go right back into this show, of course, but,
Mhm. Well,
but
my
nonetheless, so yeah, we
mother's was
just
on
don't
the
do it.
18th. My
What's that?
mother's was on the 18th.
Oh yeah, cool,
Yeah.
cool.
So
Pisces must be a great though. No.
right, she's a
Well,
great girl.
so today we are going to get into a subject that actually is the subject that brought Rob and I together. So, and in general, just two professionals wanting to know more about certain topics, and we're connected. Like we've said in the past, we were connected by a third person who knew us both and said, "Hey, you guys need to talk." And so this topic started off our conversation, and it's the topic of ventilators in the 911 setting. So I come from a world where ventilators are not, they're an everyday thing. My respiratory therapy background, respiratory therapist, of course, for 10 years before I became a paramedic. I dealt with ventilators on a daily basis, every shift, whether that was in the ER or the ICU. So I have a different philosophy of ventilators that I think is different than what would a 911 system would deal with. So when it comes to that, I'm kind of clueless on the ventilator, system. So I want, Rob and I said that this is going to be one of our most impactful, discussions because, where he's at, they have implemented the ventilator, and I've got a lot of questions. I always thought that we would just never have 911 ventilators. Like I've been on private ambulances where we had them for inter-hospital, and I'm sure that, do you guys do inter-hospital stuff too at all?
No, no.
Okay. All right. But the private world, which does have ventilators. So I was
Yes.
in it for just that stable ventilator patient, transfer them from nursing home to CT and back. Like that was what my world for back in the back of an ambulance having a ventilator. But this is a whole different thought process. So I've dabbled, like I've actually saved his explanation to not tell me a lot of stuff because I want to know about it in the moment. So we're basically going to go on a situation where he's going to be teaching a respiratory therapist about ventilators. So that's kind of cool.
Probably
So,
not, but probably
no,
not.
I mean
But
you'll be teaching like the concept and the settings and stuff like that. Yeah, you're not teaching me that, but the whole concept of why ventilators for the 911 system. So let's go ahead and dive into the very beginning, Rob. Start from the beginning about what happened when somebody came to you and said, "Hey, this is what we want to do. Help us figure this out." So start at the beginning, and if I have any questions as we go through, I'll do a little hey pause, or do something to have you
Yeah,
stop, and I'll ask a question. But I
call the
really want
lefty.
to know all about this. I mean, like I said, I've purposely not wanted to know a lot about it, even though I wanted to ask him questions. I said, no, I want this to be raw and fresh when we have our podcast. So
Right
here we
on,
go.
right on. All right. Well, so I was approached. I have a commanding officer. He's a commander for our division for education. It was right about the time that Whole Blood was coming out. We were getting new radios. Like there was a lot of change and new things that were coming out. And I was put in charge of developing the not only the education part of ventilators, but the protocol of ventilators. So in that job comes, you have to come up with a lesson plan. You have to come up with documentation of competency. Like, how do you test this out? How do you prove competency with everybody going forward with initial training, then with con ed training? Like, it's such a cumbersome, like, large amount of things that comes with that. So when I'm given a task, my first thing is to kind of like break it up into sections, right? So the first thing that I tried to do was to find out who else is doing pre-hospital ventilation,
Sure.
and it was really hard. It
I
was
bet,
really hard.
because I'm like, I mean, I'm
It
in
was it
I'm
was
in a
tough.
city as well. I'm surrounded. I'm in a department that is got a lot of EMS around it in Central Ohio, and I
Yeah.
don't know of anybody doing 911 ventilators yet.
So there's a few.
Okay.
Shout out to Chief Smitley at South Lorraine, who sat me down with a partner of mine in education and went over his protocols, went over how they deploy it. He was huge. There was other entities like in the country that I reached out to that were doing this, and they were very nice with sharing their information,
Yeah.
such as you've done with the pediatric CPAP. Like you
Sure.
shared
Yep.
info, right?
Yep.
It was one of those things where you just there's nothing online. You just have to reach out to who's doing it and figure out how they do it, and
Gotcha.
how they take such a complicated thing and really simplify it in a way where it can be used in the pre-hospital setting. And I'm going to tell you, we probably use less than 25% of the capability of a ventilator once
Really?
I've learned everything that we can do with a ventilator.
Okay.
And a lot of it depends on, which we've talked about before, what's your transport time? What are you using it for? What are your capabilities in your protocol at that moment? So the first thing I did was data gathering. Let's just look at what the protocols are, and what are the different settings? Where are people using this for? For
Sure.
example, less than half of the departments that I talk to actually use it on cardiac arrest. They cite alarm fatigue. Every time the
Oh.
compression goes, you're going to get a high
Yeah,
pressure alarm.
it makes sense not to actually do a ventilator during compressions. Like, just real quick about the hospital setting that I come from, where ventilators are a daily thing. You come in, you're like, okay, do I have 5
Yeah,
ventilators a day, or do I have 8 or more, when it comes to
sure.
the management of the vent. But when you're in the ER, you don't know. Sometimes you come into the ER and you have people that are already on the vent from the night before or the shift before, or you get people that come in emergently. So a cardiac arrest comes in. The first thing that I do is I take over bagging, make sure everything's plugged in right, make sure we got an airway, and I'm using a BVM during the cardiac arrest. I never once think about grabbing my ventilator, which is right next to me, because it's in the trauma bay. I don't think about grabbing that ventilator and putting them on in the compression phase. So I guess I didn't even realize, are there departments that are putting the ventilator on during compression phases?
So we have a setting that we can use that for. And
Okay.
I actually, so if you go online, there's a study that came out of India that talked about a 6 dial turn phase. So you could actually try to tweak some of the numbers on a ventilator to make it not do that. It, when you think about it though, like, is it really in a cardiac arrest? Is it really something you want to focus on in that first 10 minutes?
No,
I
I
don't know if
I
I
don't
would
think so.
recommend, I would not
Yeah.
recommend somebody using a ventilator. I think a
Right.
BVM and some sort of ventilatory feedback device is efficient, right?
Okay.
And we'll talk about the importance of tidal
Sure.
volume so it's more for, like, for me, if I'm working on the truck, it'd be more for transport and ROSC. And we'll talk about
Yep.
also, I'd like to talk about the importance of lung protective ventilation after you gain ROSC.
Yeah.
So going back to the training, so I gather all this information. I start to figure out how would we use this in the pre-hospital setting, right? So it kind of boiled down to 5 people. Cardiac arrest, maybe. Okay. One of the main ones is what you touched on in the first few seconds of talking. We do have transports of people from either SNFs, or nursing homes, or even homes that are
Okay.
ventilatory dependent. So how
Okay.
can we best maintain a standard of care for them? So you're talking about continuing ventilation on somebody that has a pulse, right? Well, there's also the situation of you intubating somebody with a pulse. How do you best maintain, cardiac output, absolute volume, that kind of stuff? Well, now you have a ventilator. The main, the really big one for us ended up becoming BiPAP. So we've always had CPAP, portable CPAP through the GoPAP, I think is what we use. Um, it works great. Actually, we had those old yellow bricks that would
Hmm.
suck down oxygen like it was their
No, they're
job.
they're great for the support. It just
It worked. It worked.
they bleed oxygen like a sieve.
Yeah, and I always thought that those were better than this is my personal opinion. I'm not speaking for anybody else. I always thought that those worked a little bit better than the portable ones. And then looking at the ventilator,
Wait. When you say portable, and you mean
I'm,
disposable?
I'm sorry, disposable.
Okay,
Yeah,
okay,
yeah,
okay.
yeah.
I
Um,
I totally agree. I totally agree. However, that's that whole concept of capital volume and 28 trucks compared
yes.
to disposable volume and how many disposable you can you buy for one capital. And back when that yellow box was around, if I remember right, they were a couple $1,000, 4 or 5 thousand bucks.
Well, all of our trucks had them. So
Yeah,
every one of our trucks had those. And
yeah,
then the disposable ones came out, and we went that route. Um, but now we have the ventilator, which it's
right,
it's a little different, right? They have to trigger the breath, but it's a true ventilator type of BiPAP. And I remember what CPAP did for CHF patients.
sure,
And we have a lot of respiratory patients, so BiPAP has been huge by far. I think the most usage has been through BiPAP. So now we have BiPAP, CPAP, cardiac arrest, and then intubation with a pulse, whether we did it or a hospital did it. And that was where I kind of narrowed down the idea of, okay, how do we use it in those arenas? And the first thing that came through, all of the research that I did was volume. ARDSnet, looking at ARDSnet, looking at understanding appropriate volumes through, and how do you measure those volumes? And then that took me through, the very first part of the training was trying to figure out, like, why does volume matter, and then you start going back to A&P and
sure,
understanding cardiac output,
yeah,
barotrauma and all these things. So okay, cool. So now we come up with that idea, and then it was like, listen, this has been my ventilator right through my career.
right.
I don't know. I know PEEP is kind of through CPAP, but like understanding PIP and like all these new words. Well, now I have to learn this in a way where I can then translate it in a
Right.
in a more efficient way. So I need to efficiently know more about ventilators than
Right.
anybody else.
Well, and one thing I want to just back up real quick because of this, and what we're doing here is the
Yeah.
Ambu bag, BVM. You know, honestly, we are not as proficient as we think we should be with it. When you really dial in, and I've done some research and some background stuff, I went to a conference a couple months ago, and there was two or three different companies out there with Ambu bag like feedback, programs and devices. And of
Mm.
course, we do know the Zoll has the new, we're getting it. We just haven't got it yet in my department, but we're going to have the feedback for the tidal volume on pushing into the patient. We don't get the in and out. Like some of the devices out there are very sophisticated and they show you in and out, right?
Oh, that's
And
nice.
of course a ventilator is going to be able to show you what your exhale tidal volume is for the most part. But one thing that I learned even at that conference was I went over to see what it was all about, and I started to use it, and I started bagging, and the person actually said, "Wow, you're actually really good at this. Where are you training?" And I'm like, "Well, I'm a respiratory therapist." And they're like, "Oh, okay, all right, so
Sure.
you've had many years of muscle memory of how to do it properly, teaching." you know elder therapists teaching the younger therapists back in the day, hey dude, you don't breathe like that, you got to breathe like this. So as a whole, EMS, and I'm sorry to say this, and I hope if I offend somebody when I say this, because you think you're the best paramedic bagger ventilator in the world, trust me when I tell you, you're probably not as good as you think you are. And because there are plenty of seasoned veterans that just don't bag properly. And then what do we end up doing on a cardiac arrest when it's important to make sure that we give low tidal volumes and we don't breathe too much for them and we're not hyperventilating them by accident? We give it to the lowest man on the totem pole on scene. So,
Yeah.
for us to say, wait a second, we have something now to, and where I think I'm really interested in hearing more, which I know you're going to go into, is that lung protection. That's why I wanted to bring this up, because
Sure.
we have often felt that we know hyperventilation hurts for cardiac arrest, a post ROSC. We know it, we just know it, through all the different studies. Hyperventilation or too much volume and still low rates, this too much volume can affect your blood flow back to your heart. You're trying to create a negative pressure inside the chest when you're doing cardiac arrest. When you're putting positive pressure too much, whether that's too many times or too much volume. So that's why we have these regulations in cardiac arrest where we don't want to be more than 500 tidal volume, or we probably want to be more like 350, right? So the
Yeah.
ventilator can really help with that. So sorry, I didn't want to get too off track there, but
No, no, no.
yeah, the
That's
BVM thing, even though we think, oh, the BVM, I can bag with the best of them. When there's plenty of people out there who thought they were experts at BVM, that when they get put on this device that actually shows how you're bagging someone with feedback, they realize how detrimentally bad they are at BVM.
and I feel like when you actually talk about those whys, m- the majority of the people want to know this. They want to do the right thing, right? So
Yeah.
we actually bringing up the ventilatory thing on the Zols, we utilize those in the field and we utilize those in training. So
Yep.
anytime we have
Oh,
a
that's
training
huge.
thing,
Yeah.
we talk about like even like AHA, like if I'm gonna go through the AHA, airway station, we're gonna attach an AccuVent because I want people to get really good with it.
Yep.
We teach it to our first
Muscle memory.
responders.
Yeah.
Yes. And there is a technique, and you talk about how you hold the bag and maybe like, different stuff like that. So the AccuVent was also a nice little side gig that came out of this ventilator because of the tidal volume, because of understanding those dynamics of your lungs are dependent not on how much you weigh, but how tall you are and unfortunately what gender you're born. So,
Yeah.
I could be a
Ideal
6 foot
body weight.
male that's 150 or 450. My lungs are the same size.
Yep.
So
Exactly.
when I put too much pressure in the chest, what am I taking away from? I'm taking away from blood flow back to the heart. If I'm bagging somebody on a cardiac arrest and I'm overventilating, if my lungs take their max, where does the rest of that air go? Into the belly,
Yep.
right? So now I know if I'm going to show up on scene, I have two problems. One, I'm going to open that airway and see a bunch of fluid and probably vomit in the back, knowing now there's aspiration and the patient probably doesn't stand a chance. Also knowing that all that air will probably push on the inferior vena cava, and now I'm also creating less blood flow back to the heart. So in essence, if that's been going on for a while, am I doing CPR on a dry heart? Am I not pumping any blood?
Right.
What blood am I actually pumping to anybody?
Yeah.
So that was a huge eye opener for me, was like tidal volume and the importance of it.
Right, exactly. And that's so how did you when it goes and like you said, we're still walking through the process of you getting them implemented. So
Yeah.
when you learn that, and I'm sure you learned that through someone telling you from another department about the different places, what happens when you need to teach that and try to teach the significance of what the ventilator does during cardiac arrest or in that ROSC factor?
So that came in our actual training. So we were writing the protocols, obviously, and all that stuff has to be approved through my commander, through the medical director, through the commissioner. Like this stuff is like double, triple check, right? So I understand I have these 5 patients that I had to look at. How do I work them out? I know volume is hugely important. We know that pressure support and non-invasive can alter blood pressure. We've always known that in CPAP. Now we have this new treatment of BiPAP. So how do we make this work? Zoll came out to us and gave us a very comprehensive training on the entire ventilator. And the guy that was the teacher, excuse me, he was as an educator, watching another educator go, this guy was on point. Like he had his 45-second to 1 minute speeches down, and I'm like, man, this guy's a seasoned educator. But I think they came in more respiratory therapy, and it confused people. They're like, oh my God, there's so much to know on this ventilator. And then
Right.
everybody's paranoid to use a ventilator. So as I'm watching this occur, I'm like, okay, I need to teach that information. I need to take it in a way where I make it a little bit easier to understand and kind of cut the fat. So then what we did was create a second set of training, which then dealt with our protocols, the main stuff that had to deal with what we were dealing with, and then kind of like not focus on some of the other things. So we really focused on volume and pressure and the understanding of both of those. We what damage can be done, how to fix problems through dopes, right? How to actually figure out volume, because what do you guys have in the field to measure height,
Yeah. Are they
right?
longer than the cot or not? No.
Exactly. Like, right. So the cot bed is 6 foot. So now we have something. And then then, it's like, well, if you go to a nursing home, you know what the settings are. So we just match them. But if you're finding somebody in the field and you intubate somebody, you want to you're not going to plank next to them and like, see, like, I
Yeah.
know I'm 6 foot, what are they? So, it was kind of like coming up with some ideas. The nice thing about the AccuVent on the Zoll is it gives us a range of green is good. So
Sure.
if you kind of are in that range as well on the ventilator, like you're still giving that lung protective ventilation. And that's really one of the major things we focused on, because being able to focus on that with the ventilator and the AccuVent, if the ventilator fails, well, now we still are doing the right type of care for the patient, regardless of what we're using in that setting.
So
Right?
real quick on that AccuVent, the AccuVent is I keep on calling it BVM assist,
Yeah,
but it's
there's real BVM too. There's names that
yeah. Whatever the AccuVent that's on the Zoll, that's what you're talking about. The little
yes,
blue
yeah.
adapter that clips on inline, another stackable thing inline. Probably
Yeah.
do you guys put it before or after your cap? No.
So it goes tube, capno, real BVM, and then we want capno close to the patient,
Sure.
real BVM closer to the monitor.
Okay. So with that real BVM and or AccuVent, they're
Sure.
synonymous, right?
Yeah.
Okay.
Yes.
So real
Yes.
BVM and AccuVent are the same thing. There's just two different ways to that different people call it and what they call it from Zoll. I can't remember what Zoll actually calls
So
it.
I think the term is a ventilatory feedback device. I
Okay.
think is what the term is.
Okay.
If you were to just say it blankly.
Okay, so that feedback device that's in line that we can when we're bagging, we say bag to green, and I can't wait to start training on that as well. I'm so stoked about getting those new device. We're getting the brand new Zoll Z series, so I'm super excited for that because it comes with the AccuVent. Where I know that X series had the AccuVent, but we never upgraded that. We just upgraded to the new monitor, so I'm super excited for that for the training purposes, so we can start getting muscle memory. But my question is, do you guys put that AccuVent in line with the ventilator too?
No.
Okay.
No. It's so the idea is if we can't solve an alarm rather quickly, like how many breaths can you hold?
Mhm.
If there's a problem with the settings, whatever's going on, patient's not taking the vent, the AccuVent is an appropriate backup because we can just take their tidal volume and bag to the tidal volume that they're at, or bag to green, to where you're just not doing it blind anymore. Ventilating somebody, first of all, that's awake and has a pulse can be painful to that person. You know what I mean? So we don't want to cause harm to somebody. So at that point, we're just kind of, how do we, how do we do a standard of care? Well, a ventilator patient should be on a ventilator, but if that doesn't work, we have now something to where we can at least get close to their volume, make them comfortable, not be, terrible, because we do get calls from nursing homes that are non, they're not necessarily a ventilator call. Could be, the patient has abnormal labs or there's
Sure,
something
and
else
they
going
but
on.
they're on a ventilator and they need to go to the hospital. Right.
Exactly.
Okay.
Exactly. Yeah.
Yeah. So when you guys implemented this, when it came to getting do you guys have one per truck, or do you guys do it on do you guys do it on a chase vehicle, or how does that work?
So every truck has it.
Okay.
So every person had to go through it. Even our EMTs had to go through the training.
Sure.
Obviously, they can't touch it.
Right.
And then we had the initial training by Zoll, and then we had our training, and then through our training, they actually got signed off. So we had instruction, hands-on test out, and then written test out, and then they get signed off. And then it became, how do you train it for the future after that? So obviously we have academies, so they get that initial training, but then we built a Con Ed type training that's not the same thing. It's just kind of like it evolves with, anything that changes in protocol or whatever. We go over the stuff. We do more scenario type based hands on.
Right.
It's just an ongoing. Everybody kind of does it. There's people that have come up outside of training just on their own time, like, hey, I want to work on this ventilator a little bit, and I'm there 5 days a week. I'm like, I'll set some time aside and
Right.
we'll do a couple hours on a ventilator and get
Right.
you comfortable, right?
Now ventilator calls, like calls that a ventilator, and I know with you probably have a run report system where you can pull up and see exactly which runs had a ventilator. Do you guys, because some places in general, like every single cardiac arrest gets reviewed in my department, like
Okay.
plain and
Yeah.
simple, it gets reviewed, and we have a talk with the crew, no matter what happens. If we start compressions and we do cardiac arrest, whether we terminate in the field or we transport to the hospital, either they all get reviewed. Do you guys have a mandatory review category for ventilator patients?
Yes. So and for both actually, because we're on the CARES report, so we do cardiac arrest as
Sure.
well. We get all those reports and ventilators. Basically, all the new stuff. Blood gets reviewed. And then the medical director can just say, "Listen, I want to review these type of calls." So we
Sure.
have a whole QI department
Yeah.
that is pretty much at the whim of, and they have their, we do trauma and non-refusals. Obviously, there's like mandatory stuff, but especially the new stuff. You want to make sure that you're doing it right
Right.
and you're documenting it right. And you're how do you find the errors if you're not looking for the errors, right?
Sure.
So
Sure.
yeah.
Well, another thing too, my world of ventilator, especially the ER, we heavily sedate or paralyze a patient in the ER setting for ventilators because we want to control them, we what have you. When knowing that you guys don't have RSI, so you don't have paralytics, do you guys have a protocol for ventilator patients, no matter what kind they are? Except for, I mean, I get BiPAP. You're not going to snow a BiPAP patient because they're on
Sure. Yeah.
BiPAP.
Right.
They're
Yeah.
spontaneously breathing. But when
Yeah.
it
That
comes
wouldn't
to
work.
yeah, no, that would not work. That's contraindicated. I don't want to contraindicate myself.
Right.
But
Right.
when
Right.
it
Right.
comes to
Right.
non-invasive ventilation through your ventilator, so when it comes to whenever you're doing AC, SIMV, or any of those, any ROSC, post cardiac arrests, any of those respiratory distress patients that you would decide to intubate and then manage them on a ventilator, what do you guys do for sedation to make sure that they're not always bucking the vent?
So we do have a protocol for that. Like, especially if we're trying to protect the tube, we have protocol for that. We're not quite at RSI yet or DSI. I know you talked about both. We do have protocols that we can snow somebody, for lack of a better term, to protect that tube. But
Okay.
again, we want to make
Does that
sure.
involve paralyzation too, or no?
So it evolved. It usually no. There's no paralyzation. It's not RSI.
Okay.
So
Well,
they
even I mean,
it's
because we've done plenty of intubations in my past in the hospital setting where we intubate them and then they start waking up or they become a little bit more aware, and then we're like, okay, you know what? They've got a tube. Let's just rock them. So they're
Yeah,
down
so
for the
we're not there
count.
yet. We're not there yet.
Okay. Okay.
So we can effectively snow somebody and with certain medications through our protocol through the county. And there are some departments in the county that do RSI. The idea though is that what we teach is to make sure that we're doing the right thing at the right time. Would I want to snow a septic patient that's coming out of a nursing home that's breathing fast on the ventilator, causing maybe a breathing alarm?
Yeah.
They don't need a sedative, but maybe a ROSC patient would need something. So we do get that in depth in the training. Like
Okay.
who would we want to snow? Who is breathing in a certain pattern because of their physiological problem that's going on? And understanding, well, what do you do then?
Right.
Is the ventilator even indicated then? Do you do, one patient breathe, two patient breathe, three patient breathe, and, try to breathe with them old school way with the AccuVent, trying to still make sure we're doing tidal volume until, we get to a point where, maybe there is more in depth in that kind of stuff with protocol and, whatever we can do. But at the time, right now, we kind of have to understand the ventilator is a great tool. It could do harm if it's not worked if in the right way. So I don't want to, I didn't want as a trainer to put too much on the people that are getting used to using this right away. So my thought was, how do we simplify this initially? And then working with, my bosses and the medical director, like, how do we get a maybe like a starting ground for how we use a ventilator pre-hospital and then build from there. Once everybody gets to the point of, hey, we're pretty comfortable with what we're doing here,
Sure.
then maybe it's up to them to push the
Yeah, let's
protocols a little
expand
bit
now. I want to
further.
learn more. Right.
Exactly.
So where
But
did
but
you only have like like certain topics or certain type of patients, and what were those first few?
yeah, so those were the five. So it
Okay.
was
There was
cardiac
5.
arrest,
Okay.
right? So cardiac arrest, which was if again, depending on the setting, do I expect somebody to bring a ventilator in on a cardiac arrest where I'm worried about them compression shock? We have an AccuVent on the monitor. So you're right. We intubate somebody with a pulse, so somebody goes apneic or we need to take an airway, somebody anaphylaxis or coming out of a house fire or something. Also, are we transporting out of a
Sniff.
facility or house
Right.
that is vent dependent? So those were our three invasive. And then we've
Okay.
already done CPAP. So then it's CPAP and BiPAP,
Okay.
right?
Gotcha. Gotcha. Okay. Yeah, and then that kind of leads to when we first just started discussing pediatric CPAP, and then the Ohio, scope of practice at the time had some sort of weird wordage about 16-year-old trach patient ventilator, and it wasn't spelled out for these new ventilators,
Mhm.
and it was really cool to talk to you about that, and then and as we got through stuff and I ended up speaking with the Ohio medical director, and one of the things she explained to me about our scope of practice, and it really made a lot of sense, because I saw her at the convention. I'm like, hey, I want to talk to you about something, and because CPAP has been CPAP, and we've been doing disposable CPAP on kids for 7 years in my department,
That
and
long.
yeah, exactly,
Wow.
yeah,
Okay. Yeah.
yeah, easily, and then when it comes to CPAP on ventilators, we know that transport vehicles like helicopters or hospital to hospital, especially children's hospitals that have a mobile NICU unit or what have you, they're
Mhm.
doing ventilators, they're doing CPAP, they're doing BiPAP, so we know it's capable of doing it. But then as we talk about the 911 setting, how she explained it to me when I talked to her, she said, Kyle, basically here's the simple fact. First of all, I have to defend your scope of practice in a court of law. So there's that.
Yeah. Yeah.
You mess up, I have to defend you essentially. Okay, fair enough. And then she said basically what happened is our technology has now it grew so fast, it outgrew the wordage of our capabilities. So with that being said, they have been talking about it for several months or weeks, or I don't know how long. My one of the people I know well sits on that committee and knows that they had been dabbling in it. And then the wordage, I'll never forget the date. February 19th is when they put it out. Is when they actually changed the words and talked about any age for what was the actual wordage?
I
Uh,
think non-invasive.
well, non-invasive, but the way that they talked about the multifunction ventilator, that's what it was. So the
Sure. Yeah, that's right.
multifunction,
Yeah.
so the ventilators that are out there in the 911 setting have multifunction, meaning, they do SIMV, AC, and BiPAP and CPAP. So
Mhm.
those are multifunction. And they needed to have that specific wordage in there to be able to cover their butts per se, and our butts, to say, hey, we've trained these because we're capable of doing it. We know paramedics can do ventilators. We
Mhm.
know paramedics can decide when someone needs to go on CPAP, BiPAP. So it was just one of those things where they had to catch up and have the wordage right. So I applaud the state for all the time that they put into it, and the timing that they did it. These ventilators are becoming more and more of a hot topic, and to actually have the wordage now in there that patients of any age can be placed on multiple function ventilators in BiPAP and CPAP mode, which it was really great, because that ultimately is going to move the other, hot topic out there right now, which we're trying to, me and my team, we're trying to make it a hot topic, is pediatric CPAP. They've been doing it in a hospital for years on regular BiPAP machines that are specific to it, and with transport ventilators. So why can't we do this in the field with our disposables? And we have proven, like I said, we've got about 40 patients in the database that we're looking into now and doing all of the study stuff to get the outcomes, so we can actually have something in writing that says, hey, even with the disposable CPAP devices out there, we're having a lot of success for these type of respiratory distress children. But the big hang up when you and I were talking was there was no ventilator wordage, and now there is.
Yeah.
So we'll put the link to that in the bio too. I mean, in the show notes section, directly to the part of our Ohio scope of practice that talks about any age, and it talks about CPAP and BiPAP and multifunction ventilators. So that's super exciting for Rob and I, knowing that that is a holdup for some departments. And the good thing is discussions like you and I have, and discussions with these medical directors, and being at the medical director convention that I was at in January. A lot of those medical directors, they're ex paramedics. I don't know if you know that, but a lot of EMS medical directors were already, they have a passion for EMS because they were
Yeah.
paramedics first. So,
Yeah.
but
Yeah. Yeah.
so you mentioned when it comes to your medical direction, did they have to be educated about 911 ventilators too, or did they already have it in their system where they were at before? Like talk to me a little bit about and it feels like I'm interviewing it, but it's not like I'm interviewing. I'm like, I get these questions that pop up as we talk about this, for the purpose of of me not wanting to know a lot. This is why, because these are the kind of questions that people listening may want to know. Like, okay, how do I approach my medical director? Is my medical director going to just shut me down?
Sure. So I want to say two things before I talk. One, I remember the night that came out,
Yep.
the language changing and talking to you and like calling you after we've already talked for a while. And I'm like,
Yeah.
dude, I'm sorry, I don't mean to bother you. And I do look forward to the podcast where I can be on the other side of this and interviewing you about pediatric CPAP.
Yeah.
So
Yeah.
I
That'll be
do look
exciting
forward to
too.
that. Yeah. As far as the way that my position works is it the what I teach is kind of dependent on where the medical direction comes from and the leadership. So they decide what we're going to be doing, right? So the decision was ventilators, and we're getting ventilators, and then they do the test out on ventilators, and then my boss comes and says, you're the ventilator person, you're the respiratory person right now. Then it could have been anything, it could have been whole blood, whatever the situation is, whoever's available, just gets kind of like, called up to the plate. So, as far as what's done with the ventilator, I do have a good dialogue with our medical director. I do also now have that position on the union where I can also talk a little bit more freely with the medical director and talk about, maybe where our union would like to go as far as representing our members and what we'd like to do. But again, I have to, I do kind of sit in that area where it's like, I don't necessarily know what all the plans are. So maybe there's like three or four other training things that are coming down the pike. That's like, no, you have this coming up in like 6 months. So when it comes to either any changes in a ventilator or changes on how CPAP and BiPAP are done, that all comes from the top. Our commissioner, our medical director, and then that goes end up to the command staff, and then they delegate, this is your job, come up with this, that, and the other. So um, I'm always happy when new things get put in the lane of Cleveland EMS. I know there's a new EMT skills that were put out a year or two ago. Again, whole blood kind of came out at that same time. All the finger thoracostomies, like there's these new nice adventures that the state is putting us on as pre-hospital people that I welcome as an instructor, and I want our people to be able to do, because I know that the more that we can do, the more top stuff that we can do, the more that we can shine, nationally, and try to really make sure that people understand how important EMS is
Yeah.
in
Yeah.
general, right?
And that's once again, I think we even talked about this on the last podcast, is that you know because of my background, I have always felt that even in EMS, I'm part of the healthcare system. What I do on scene can affect that patient later on in the hospital. And that's taken a while for the true EMS people that have never seen both sides of the fence to come to the realization, like, wait a second, I am part of this healthcare system. And that's
Mhm.
important too for us in general. That could be a topic some other time too, we're not paid like nurses. You know what I mean? We're not, if you're a firefighter paramedic, you get a little bit more money because you're two different entities. But the majority of the runs even in the fire EMS system are going to be are going to be EMS oriented emergency runs. Not as many fires as there used to be, not as many car accidents that are detrimental. Don't get me wrong, we still have them, but for the most part, we run a lot more EMS calls as a whole in any community than we do strictly just fire.
Mhm.
So for us to change the mentality, and those of you that are listening today, and if you don't think you're part of the healthcare system, I really I beg of you to rethink that, because what you do and why we are learning some of these advanced cares, ventilators, pediatric CPAP, whole blood, finger thoracostomies. I mean, I've even heard, do we have the uh, pericardiocentesis too that we can do? Is
I don't think so in Ohio, no.
but there are paramedics in the world that can do it, right? So like that's crazy to me,
Right.
that's like what? But you have to understand, like we are getting more and more put on our plate, and we're not being paid like a medical professional in the hospital. I really think that we should be as equal to respiratory therapy and nursing, because we do the like. One thing that I never had to worry about in respiratory therapy was delivering a baby, right?
Mhm,
I had
yeah.
to worry about the airway possibly of the mother or the child after it came out, but I never had to worry about the birth. There was other people there. Well, I become a
Yeah.
paramedic, and wait a minute, I got to worry about birthing, knowing that. I got to remember cardiac arrest, which, once again, I was an airway guy for cardiac arrest. I didn't have to know all the drugs, even though I had to do the ACLS and know them. I didn't have to really know them like I do as a paramedic. There's a lot of things as paramedics. We are this multifunction entity of the healthcare system, and they don't like see us that way, and it's a mindset.
Yeah. Yeah. And it's unfortunate for the most part. I have to shamelessly say that we do get paid at Cleveland EMS like nurses do. We are fortunate enough to have a very medical uh, centric city, and an understanding of safety forces from city hall down, and they really do care about us, and we are paid, when you talk about parity, better than most of the country. And I
When it
just
comes to
read an
EMS
article.
only, yeah,
Yeah,
yeah.
and
I
I
mean,
just read an
you've
article
got fire
about a
departments
fire.
out there, and
New York.
yeah.
New York EMS
Oh, that's
has a
huge in the
huge.
news right now.
Right. So we are paid.
Right,
I mean, we are doing well in that setting, and what I would say is, as again, as a union board member, fight for that. If
right,
you're a
right.
union, that's how you're going to get quality people to come into your city,
Yeah,
and have the education, the background, the years in service. That's how you're going to get people that are looking to upgrade their
right.
setting of care that they want to do. So anybody that's listening out there that's on a union or has to deal with that, funding is the number one thing for your members. If you can get them paid well, you're going to get retention. You're going to
Right,
get people buying into systems, and then there's a little bit of luck. Does your municipality, how forward thinking are they in
right.
medicine? Because you had mentioned something about more we're doing. Well, medicine really just kind of pull from one spot and then pull to another. So, what kind of stuff can we do that the ER would do in the first 20 minutes? And that's
Sure.
usually what ends up bleeding back out. And if you mix that with military stuff that we get for trauma, well, now you start looking at all these new things. I mean, I'll take you back to when I started in the SWAT days. We're going back to 2007. 2007, we had to talk people into tourniquets.
Oh,
Now, tourniquets are
yeah,
something right
yeah.
now that is
Standard.
it's
Like,
standard.
yeah,
But people were nervous. You were always told, "Oh my God, you put a
yeah.
tourniquet on, they're going to
You
lose
can
their
lose that
limb." And it's
arm.
like,
Yeah,
wait a minute,
yeah.
they've done tourniquets and surgeries for 10 hours. But that was a sell. Like, we had to talk about that and
Right.
show the data. It's no different than ventilators. It's
Yeah.
no different than showing data. And how is this going to improve care to somebody, getting it earlier in their problem,
Right.
so then they can have a better outcome?
So, what was the biggest obstacle you guys had to come over when it came to implementing the ventilators? Was it the cost of and number of ventilators? Was it the training? Like, talk a little bit about where you felt the biggest pushback and how you overcame that.
So I'll talk about my standpoint, because I don't know about the
Yeah, yeah, yeah,
cost and,
yeah.
and that
Just
kind
your
of stuff.
yeah, and that's
My
what we're talking
standpoint
about.
was
Yeah,
was buy-in.
buy-in of
Was
the
I mean,
people
because
on the
now you have,
street.
yeah, because now you have another piece of equipment that you have to
Sure,
carry in. Y- I mean, like, we're talking about ventilators right now and all these different things. You're going to get people that are going to be like afraid to use a ventilator,
sure.
and for lack of better words. So, buying in. So again, my job was to take all of this information and just become an expert on ventilators, and then simplify it in a way where I could use it in a 2-minute oh shit situation, or Or do I even use it in a 2 minute oh shit situation? And now I have this AccuVent, which again, like I said, kind of became the side quest of this whole thing. Well, we have something that gives us volume. So how do we maybe get the patient stabilized enough where we're controlling volume and then put them on a ventilator?
Sure.
Then it kind of became like, well, do we need to rush it? Like, there was all these little kind of things that came as I realized, like, and tried to implement it in my head. How would I use this in the field? Well, I need to know how I would use it, and then talk to other people how they would use it, and
Sure.
that kind of became my path to success
And
with
what
the
was
thing.
the timing from when you made the decision of getting them on the trucks to when they went live? Like, how long did it take for that training?
Zoll came out and did like all of our people in like 3 weeks or whatever. I mean, it was like all day long, and I'm my job at that point is to make sure that everything runs smooth. We have documentation of everything, but then I'm also writing another uh, um, training module while he's doing that. And I'm looking like, okay, we need that. We don't need that. We don't need that. Yes, this is great. We don't need this. And then I had to inject that into our protocols. So, and then, protocols have to be approved by medical direction. So it's not only creating the training, but then it's creating the protocols and making sure the
Yeah,
wording is done right.
that's
So
a big lift. Yeah, it
yeah,
really is.
yeah,
Yeah. Yeah. I can see, someone like myself would not have any reservations of adding a ventilator to my system. But I can definitely tell you that there would be a lot of people in my system that would be like, "What? Why in the world?" So we would have to take them down that journey of care of
hmm
why it would increase the lung protection philosophy, and then we don't have a lot of nursing homes, so that would almost be off the table for us, like where some of the inter hospital transports we could, and maybe that's where it starts for us, because I'm sitting here the whole time thinking like, where, when and where would this be implemented in my type of department? And I know that it had been thrown out there for kind of even for the fun of it, of having a mobile ICU that
hmm
had my department's name on it. With we have nurses, we have respiratory therapists, we have seasoned paramedics, we have flight medics, we have medics that have their critical care paramedic background too as well, and work at different systems on the mobiles and on the helicopters. So we have a very eclectic group of people that work for us, that have bigger other areas that they are experts in as well, or even work as. But when they come, when it comes to those guys, are those the 10 or 15 people that are now your ICU team? And is that what they want to do? Like, I would be totally down with it, but I can't speak for everyone. But
sure.
and how does that look? Am I still a unit day guy, or am I sitting in a building waiting for ICU runs to come in? So,
Yeah, that would be a whole great topic that we could do, because
yeah,
I'm on board with that too, because all that does is advances
yeah,
pre-hospital EMS.
yeah,
Like where do we go from here?
sure,
Because we're kind of we're hitting this ceiling almost of, okay, we can do this amount of stuff in a pre-hospital care. What else can we do that's more of a, again, touching on the other topic we just talked about, more on scene time
sure.
that shortens the actual critical care that they need. So I would love to see more, advanced units like that, specialty units in the EMS setting. I mean, that would be amazing. And then, you start thinking about where does that go, and how do you charge more for that?
Right. Well,
Because
yeah.
you're
How
going to
does
get
that
billed
work?
for that.
Yeah. Yeah.
Yeah,
Exactly.
like there's
Because yeah,
there's a
we
lot
bill
that
now.
comes in that.
Yeah.
More money,
Yeah.
more money for the people doing the job.
Yeah.
How do you select those people?
Yeah.
So I
Oh
I
yeah,
I
yeah.
would.
You put me in. You put my respiratory therapy hat on too. I'm sorry. I mean, I'm sorry, but you're gonna have to pay me more to be a respiratory therapy expert as well as a paramedic in that scene. I mean, plain and simple. What
Yeah.
does that look like? Who knows? And then how does that is that another position in the system where, like, okay, well, if you go get your critical care paramedic, you can qualify for the ICU team, or you can qualify for the transport group of our department. And
Mhm.
and what does that do? Does that involve angst? Does that involve people saying, what, there's no way I ever want to be a part of that? So it's just one of those things where it's a great topic. I'm hopeful that we see that in my last remaining 7 to 8 years that I'm still, employed by my system before I retire. But who knows? I mean, it was first discussed 5 years ago, and I don't know if it's any closer than it was. But on the other hand, is once again, what departments like ours are out there doing just that,
Yeah.
and departments like yours that have ventilators now, you're probably a little bit closer of doing something like that. You know what I
Yeah,
mean?
I mean, it's I can definitely see it. I could definitely see it happening, and I'm not trying to disclose anything or
No,
whatever,
no, no.
but I can see that road going down there, and it takes there's again there's a lot of luck that comes in that. Do you have the medical direction that wants to push forward? Do you
Sure,
have the leadership that also is in line with that? Do you have the ability to train it? Do you have the ability to implement it fund wise? I mean, there's a lot of stuff that goes along with that.
sure.
Training costs money. You talked about making more
Ventilators
money.
cost
Well,
money. You can't be an ICU, machine, truck without a ventilator, and that's going to cost lots of money. How does that work?
but let's say this. Let's say this. We have a standard of ventilation, right? But then we want to train 30 people to do minute volume care for sepsis patients. Well, those people probably have to do more training.
Sure.
So you have to pay them more money anyway. So there's always like built in more money with that. I always think that when I train, I have three levels of people that I train. I have people that are probably towards the end of their career, like I don't want to touch that, and that's fine.
Yeah, yeah.
That's what the
They
acumen's
paid
for.
their dues. Yeah.
That's why the ECMO's for, right? So I come up with an option for them. Well, you don't want to use the ventilator. You still have the GoPap for the CPAP. You still have an AccuVent kind of a thing. Like, it is what it is. You have the majority of your people who are middle ground are like, yeah, I would like to do that. I want the training, or maybe I don't feel comfortable. And then you got your upper echelon people who have maybe done military, critical care. They're go-getters. They want to do it, right? So you almost have to create a training that takes all three of those into account, right?
Yeah.
And then what do you do from there? So now you have a baseline training. Well, then do you start looking at the people that have a military, critical care training coming from somewhere else, and you say, well, we want to do this and some sort of advanced care type stuff. These are our qualifications. These are the tests you have to take. This is the training you have to do. This is the Con Ed you have to do. That is where I see myself. Like if there's ever that kind of stuff, I'll be seeing that from the training standpoint
Sure.
of where they're coming from, and like what do they want these people to do, what do they want the training to look like, how do we measure competency, and how often do we measure
Yeah,
competency.
that's another thing. This is like, how often do you measure competency on ventilators? Because especially if it's let's say you've got a vehicle that has a ventilator, but they just don't get the ventilator type of runs, and how to keep them as proficient at it as the ones that get more ventilator type of runs. So yeah,
So what I try to do is when I'm doing Con Ed, I do have it's like a 2 hour respiratory lecture that I do that covers everything: end tidal, bagging, volume, ventilator, everything hands on to the point where they're doing mock patients on the ventilator. So we try to implement it into our everyday training. But I've had a lot of people come up outside of like their normal duty hours and be like, I just want to run through scenarios. Can you go over this again with me?
sure,
Or I'll get an email that says, hey, listen, I had this call. And when I started getting that kind of buy-in from people,
sure.
like all the way to vets, like hardcore vets that were like, man, I want to I want to get comfortable with this. I want to use it. To me, I was like, okay, this is a win. This is a win for us. This is
Sure.
huge.
Yeah. And like you said, you review every ventilator run. You probably have times where, I mean, I know our system, we get to hear, well, our medical director is very active with us. So not only do we have core competencies, we have sim house once a quarter, which is basically on duty. You show up to our simulation house, and you get dispatched on the radio on a training channel, but you come into a situation, and we're pretty good about keeping our mouth shut because you're talking about a whole entire month of sim house to get
Sure.
everybody through it. And most people now are like, you know what, I'm not going to tell you what they're going to be throwing
Good.
at you,
Good.
which is good. Like
Good.
some people will
Yeah.
talk a little bit, but most people just keep it quiet, and they're like, it's a good one, or yeah, there's a couple of things that kind of threw us a curve, but they still like, what, you need to experience it, because that's part of what SimHouse does, and that's what's really cool. And that was all decided, that not talking about what SimHouse was about was kind of one of those things that we just kind of adopted. We just felt that it was best for the person going into it. We understood what the training was. And we were actually approached, hey, by the way, when it comes to the sim house, we really ask you not to share the information because this is going to be something where it's an educational thing. It is never punitive, never ever ever. So you can screw
Yeah.
up as much as you want in sim house, and the most that you're going to get is some remedial training. So it's not punitive. And
That's huge.
we
That's huge.
yeah, that's huge. And we, I look forward, like, when if I have to miss a sim house, I'm not happy. And I'll try to figure out a way to reschedule a shift where I can go to a sim house, or I'll just call up the team and say, "Hey, I want to come to the sim house on this day where I see that there's only two people. Can I be their third?"
Mhm.
Because I believe in it. I believe in the simulation strategy. And what's great about that is we get there and we get presented at the door like and we have actors, and sometimes we have our people acting. And at one time we did a sim house that was very simple. We're actually going to do it at FDIC in April. Our team is going to be doing one of the most basic sim houses that we ever did, and it was one of the first ones we ever did. We did a crawl, walk, run thing with the sim house. We did a fall, and then our sim house
Oh,
videotapes the scene, and then they review it and they go over it in a debrief. And we found out, and there was an article written on it, and there was an abstract that was written on our sim house fall scenario. We get to see how people lift. We get to see decisions. Are people trying to extricate out of the bathroom? And what was cool is we were in a real bathroom. Like, it was actually part of our building that had a
yeah.
real bathroom. So we got to move that person out of there in a way that we would have in the first place. And you saw different strategies. It was really kind of cool. And then when we saw different strategies and what worked better, we got to go back and we retrained on it. We put that training into our continuing ed training of what was proven in our department to work best, and what
Nice.
have you. So,
I
you
like it.
know,
That's a great. Yeah, I like it.
yeah.
That's
So
a
our
great
sim
idea.
house, when it comes to like possibly ever putting in ventilators, like, that's what would be so cool about it is we would probably have a ventilator sim house before it ever went live. We would be trained on it, and then we
Yeah.
would do a core competency on it, and then we would do a sim house with the ventilator as the main focus, and then that would get people comfortable. So, it's pretty interesting. I used to be a person that would be like, there's no way you're going to put a ventilator on my 911 system, even though I'd be like, totally know how to use it. But now, not just talking to you, but then hearing about other departments around the nation that are utilizing them in dramatic ways. And, like you said, post cardiac arrest, lung volume, care, that is a huge thing for neurologically intact patients to leave the hospital. And that's
Yeah.
all we're trying to do. Any type of CPR to people that are trying to get that neurologically intact person out of the hospital. And if a ventilator actually helps us achieve that even more, then let's find out more about it. Let's do our
Right.
research. Let's figure out how this can be done.
Right.
So
It's huge in Rusk. It's huge in Rusk, and understanding that, like, wh- how long does it take to get somebody to an ICU on a ventilator that just came out of a cardiac with Rusk? How much time are we cutting out in that scenario?
yeah,
Where if we get true Rusk, which again you and I know is luck, it's
yeah,
it's it's time based. There's a lot of things. I can't wait to talk about our cardiac arrest podcast. But if we get to that point, which
right,
is few and far between, how much time are we cutting out of that type of care that is shown to prove neurological outcome function way better than
yeah,
anything else?
exactly,
So that that
yeah,
was that was that was a nice bonus because I was very concerned about cardiac arrest. Again, there's a lot of entities that said that they just don't use it. It's a pain in their butts.
right.
Um, we kind of use it in a certain capacity again for transport. But we do talk about ROSC. If you get ROSC, the ventilator is the way to go.
Gotcha. Gotcha.
Yeah.
Fantastic. Well, I think that's a great first ventilator discussion right there. I think that's given plenty of people that may be wondering how to implement it and what obstacles they may see. I think we've covered all that. It was a very educational, discussion for me just to open my mind a little bit and not be so closed off, like I have been in the past. So I'm definitely down with finding out more. Am I going to be approaching my medical director tomorrow about it? Probably not, but
Mhm.
it's just one of those those things where that's not my job. That's his job. He's going to start seeing the studies that are coming out from other departments that are having neurological outcomes, that are having better turnaround times for people in the hospital, that ventilators being used. That those studies are out there and they're coming. And we have a pretty aggressive medical director that, like, when it makes sense and he knows our system is, as good, if not better than anybody else in it, of when it's the right time and appropriate time to look into implementing something like that. But I do want to make sure that everybody knows to subscribe, like, and share of the EMS In and Out podcast with Rob Moyers and Kyle Goodnight, your two hosts right here that are bringing you conversations and discussions that may be something you know all about, maybe something you're wanting to know more about. We've got a lot more topics on the agenda. Rob just mentioned something about cardiac arrest and stay and play and all that stuff. We're definitely going to get into that. We're going to get into whole blood in the 911 system. We're going to get into pediatric CPAP and how it's spreading around the nation. We're going to get into having guests on and talking about maybe parts and places that we don't have knowledge on. We're probably going to have a discussion on RSI, DSI, and why that's important, and the process to go through, the process I went through, the process that Rob would have to adjust to if they implement it in their facility and their department. But tell your friends about the podcast. It's new. This is episode 2. So
2, yeah,
we've got the intro. That's not really an episode, but this is episode 2. You're going to have both of these on the first day. Our launch day is on the 19th of February. We'll have both episode 1 and 2. March 19th, sorry. March 19th, we're going to have episodes 1 and 2 ready, and then we're going to go weekly on every Thursday morning. I think I picked 5 a.m. just to make sure that we cover all those medics that are heading to work that may want to jump on Thursday morning.
Yeah, that's great. Yeah. I mean, thinking about that. Yeah. Yep. I know that we plan on having a nice bank of them. So we want to really push this out and get a good group of people. I have some people that I work with that are excited about hearing these. So I look forward to pushing them out. I look forward to hearing your experience on as we go through this, all these different topics that we've talked about. So I think this is going to be really great for people that are in the industry, that are nerds like us, that care about this industry and really want to move forward and take this pre-hospital EMS type stuff to new heights.
Yep, exactly. All right, everybody, thank you so much. Rob, thank you so much for all your information. I appreciate it. Thank you for listening to EMS In and Out. 2 systems, 1 profession, real conversations. If this episode challenged your thinking, share it with someone on your shift. And remember, keep learning, keep questioning, and always follow your local protocols and medical direction. Please like, share, subscribe, and hit that bell so you'll be notified anytime new episodes drop. And as always, stay safe out there, and we'll catch you on the next call.